How often are U.S. adults using and acting on health information from social media? Could serial amnioinfusions change the prognosis for what has long been a lethal fetal diagnosis? And what should clinicians know about the latest surgical and endoscopic therapies for GERD? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners around the world. Today is July 2nd, 2026. I'm Dr. Kirsten Bibbins-Domingo, Editor-in-Chief of JAMA. Today, I'm joined by Dr. Preeti Malani, JAMA Deputy Editor. Let's start with some of the newest research published in JAMA. The first is a study of Anhydramnios from fetal kidney failure, which almost universally results in lethal pulmonary hypoplasia. Building off the initial report of the renal Anhydramnios fetal therapy, or RAFT trial, published in JAMA in 2023, this new report from Dr. Jenna Miller and colleagues uses a prospective, non-randomized clinical trial design to evaluate serial amnioinfusions started from before week 26 gestation in 32 pregnant patients at 13 U.S. fetal therapy centers. Prior work from the RAFT trial focused on bilateral renal agenesis. This RAFT trial report evaluates other causes of renal failure, which collectively account for the majority of Anhydramnios cases. Among the 32 patients enrolled, 29 pregnancies, or about 91%, resulted in live births, with a median delivery at 34 weeks and 1 day. The primary outcome was survival to at least 14 days with dialysis access placement. This was achieved in 19 of 29 live-born infants, or 65.5%. 14 infants, or 48% of those live-born, survived to hospital discharge at a median age of 4.7 months. And among 11 long-term survivors to date, 7 have undergone kidney transplant between 2 and 5 years. There was no unexpected serious maternal adverse events in this study, although preterm pre-labor rupture of membranes occurred in 56% of participants. The main takeaway is that serial amnioinfusions is feasible and can mitigate otherwise lethal pulmonary hypoplasia, but survivors still face major neonatal and long-term morbidity.
Thanks, Kirsten. And yes, that's an important distinction. This intervention appears to change early survival, but it does not erase the medical complexity of prematurity, the need for dialysis, and prolonged intensive care that follow. So nuanced family counseling is a key consideration for this therapy, which is still not widely available.
Moving on to the next study, we just published a research letter on social media and health decisions.
Well, it's no secret that patients are using social media for health information, but relatively little has been published on how often this is happening, or more importantly, how often patients are acting on this information. In a nationally representative study, Dr. Pedroso and colleagues analyzed 2024 Health Information National Trends Survey data from about 7,300 respondents, which represented about 262 million U.S. adults. They found nearly 88% of adults reported using social media. Among these social media users, roughly 85% said they shared personal or general health information, 70% participated in online communities, and 22% said they made health decisions based on what they saw on social media. In other words, more than 1 in 5 users, which would translate to more than 47 million U.S. adults, said they had made a health-related decision based on social media content. Yet at the same time, 78% said they believed health information on social media was false or misleading. So that's quite an interesting contrast. The authors also report that adults with chronic conditions were less likely than those without chronic conditions to share health information or participate in online communities. The practical message is clear. Social media is a major source of health information and influence, even when users do not fully trust what they see.
That disconnect really stands out. People may be skeptical, but the content is still shaping behaviors. Notably, this was a study only in adults. It'll be interesting to keep an eye on this topic for younger patients on social media, especially as AI-generated information evolves. It's worth noting that this week's Healthy Dialogue podcast features a discussion on social media and health effects in children. Dr. Derek Angus, the host of the Healthy Dialogue podcast, interviews Dr. Dimitri Christakis on this topic. Let's listen to a clip.
It really shouldn't surprise anybody, certainly no sensible person, that when some of the brightest scientists, and many of them were PhD scientists and engineers, were recruited and hired by these companies and provided financial incentives to make the platforms more engaging, that they succeeded in making the platforms incredibly engaging over time. There's been an active arms race, if you will, amongst these platforms competing for the attention of children and adults. And they've quite cleverly introduced everything we know about behavioral science to make their platforms difficult to get away from.
Moving on to another research letter, this one looks at recruitment strategies for clinical trials. More specifically, does it matter who is doing the recruiting?
Well, that's a great question that was taken on by Dr. Lassen and colleagues who embedded a randomized trial within the large DAN RSV vaccine trial done in Denmark to test whether the sex of a video presenter influenced the decision to enroll in the trial. More than 4.4 million adults were randomly assigned to receive an invitation linking to an otherwise identical recruitment video featuring either a male or female presenter. Both presenters were physicians and professors to avoid bias by title or rank, and both were from the same hospital system. Overall enrollment was nearly identical, 6.83% with the male presenter and 6.86% with the female presenter. The difference was too small to matter overall. There was, however, a modest age-related effect. Among people younger than 60, the female presenter video was associated with a slightly higher enrollment rate, a difference of 0.08 percentage points. At the scale of this study, that could translate into thousands of additional participants. So the bottom line is that presenter sex did not meaningfully change overall recruitment, but small design choices may still influence participation in some groups.
Yes, this is an interesting one, and it's a reminder that recruitment strategies are not trivial, especially when trials are operating at national or global scales. Now let's take a look at some new Viewpoint and Perspectives articles. In a new Viewpoint, Dr. Nelson and colleagues discuss AI safety for mental health. They introduce some new concepts, Type 1 and Type 2 AI harms. Type 1 harms being an acute harm from a single or brief AI exchange, a single prompt failure, whereas a Type 2 harm is more insidious and only emerges over extended or multiple conversations. One of their main points is that clinicians and regulators should focus on how these tools perform over time, especially in long, emotionally charged conversations where more subtle and cumulative harms may emerge.
We also have a viewpoint by Professor Cohen and colleagues on the recent executive order supporting the development of psychedelic therapy for mental illness. They note that the executive order may modestly accelerate research and regulatory review, but it does not solve the harder problems of clinical readiness, ethical rollout, reimbursement, and equitable access once psychedelic therapies are approved.
Highlighting the new JAMA Plus Trials channel that was recently launched, Dr. Allison Wong, the new editor-in-chief of JAMA Plus Trials, and colleagues have an editorial that explores discontinuation, de-escalation, and deimplementation trials. These are studies that test whether patients can safely do less, like stopping medications or reducing treatments. The authors emphasize that these trials are critical for shifting away from the more is better mindset that is prevalent in clinical practice, but require especially robust evidence to overcome deep-seated resistance in both clinicians and patients. Implementing less can be harder than adding something new.
Let's close with some pearls for clinicians and patients. Dr. Stein and colleagues authored an informative JAMA Insights on familial hypercholesterolemia, which is a genetic condition causing lifelong high LDL cholesterol and an increased risk of cardiovascular disease. Diagnosis is usually based on high LDL cholesterol and family history, not genetic testing. Here are the key takeaways from the Insights article. Standard lipid screening recommendations from the 2026 ACC-AHA guideline recommends lipid screening at ages 9 to 11 with reassessment every 5 years, starting at age 19. But for children with a first or second degree relative with known or suspected familial hypercholesterolemia, lipid profile screening is recommended at age 2 years. You should suspect familial hypercholesterolemia in adults with an LDL-C of greater than or equal to 190 milligrams per deciliter, plus family history of premature atherosclerotic cardiovascular disease. Genetic testing can confirm the diagnosis and help with cascade screening of first-degree relatives, but treatment decisions are guided mainly by LDL level and overall cardiovascular risk. First-line therapy is a high-intensity statin. Most patients also need ezetimibe as a second line or a PCSK9-directed therapy as a third-line option. LDL goals are less than 70 milligrams per deciliter without known atherosclerotic cardiovascular disease and less than 55 with established atherosclerotic cardiovascular disease. And patients with homozygous disease or persistent severe elevation despite therapy should be referred to a lipid specialist.
Another JAMA Insights article by Dr. Thrumorty and colleagues reviews surgical and endoscopic therapies for GERD in patients with persistent symptoms despite lifestyle changes and medical therapy. The review focuses on who should be referred and which newer endoscopic options may help. Before referral for surgical or endoscopic intervention, patients should first be evaluated with upper endoscopy, esophageal pH monitoring to confirm GERD, and manometry to exclude motility disorders. Consider referral after at least 6 months of medical therapy when symptoms remain troublesome for more than 2 days per week despite treatment. There are a variety of techniques that specialists have at their disposal. Patient selection matters. Obesity, dysmotility, large hiatal hernia, and other atypical symptoms can change which approach is appropriate.
The JAMA Clinical Guidelines synopsis covers the 2025 IDSA update on antiviral therapies for adults with mild to moderate COVID-19. Here are some of the highlights. For adults at high risk of complications, nirmatrelvir, ritonavir, or IV remdesivir reduce hospitalization and are recommended. For patients at increased but not highest risk, those same options may be used after shared decision-making. Patients without risk factors for severe disease are unlikely to benefit from antiviral treatment. Before prescribing nirmatrelvir, ritonavir, check carefully for major drug interactions and dose adjustments for kidney function. Molnupiravir is only for those who cannot receive other treatments and is contraindicated in pregnancy and breastfeeding.
To wrap up, the JAMA patient page offers practical advice about low back pain. About 90% of low back pain cases are nonspecific, without a clear structural cause, and imaging is usually not needed. Patients should stay active, avoid prolonged rest, and try therapies such as spinal manipulation, acupuncture, massage, heat, NSAIDs, and muscle relaxants for short-term symptom relief. Most recover within months, though chronic pain needs more extensive multidisciplinary management.
And the JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insight into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
That's a wrap for this week's JAMA Editor's Summary. Thank you, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Kirsten Bibbins-Domingo. This episode was produced by Daniel Musisi, Shelley Steffens, and Dr. Michael Lipnick at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thank you for listening.
The script for this podcast was generated with assistance from GPT 4.1 OpenAI tools following an editor-developed prompt. The script was then reviewed, edited, and approved by editorial staff. This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.